Hi, everyone. My name is Sean Yaffe. I have the pleasure of moderating the discussion today on individualization of HIV therapy and future directions. Thank you to Merck for co-developing this event. I'd like to first acknowledge that I settled, live, and work on the unceded territory of the Kanien'kehá:ka, or Mohawk Nation, currently known as Montreal, or Tiohtià:ke. I'm a family doctor working primarily at Clinique L'Actuelle in Montreal, as well as the McGill University Health Center Chronic Viral Illness Service and the Indigenous Health Center of Tiohtià:ke. I'm excited to introduce our speakers today, who are sure to incite a great discussion on individualization of therapy. So first off, we'll have Dr. Melanie Murray, who is a clinical associate professor in the Department of Medicine at the University of British Columbia and an infectious disease specialist in HIV care at BC Women's Oak Tree Clinic, Vancouver. Her research interests include HIV and women, and especially the role of hormones in healthy aging with HIV. Afterwards, Dr. Sharik Haider will present as well, Professor of Medicine at McMaster University in Hamilton, Ontario, the head of Transplant Malignant ID Service at the Juravinski Hospital and Cancer Center, and is current medical director of HIV care.
Thank you. All right. Thanks, everybody, for staying. All right, so we're going to start by talking about individualization and the management of people living with HIV, and really, what does it mean? These are my relationships with different sponsors. And I'd like to first start by acknowledging that I get to live, work, and play on the unceded traditional lands and waters of the Coast Salish peoples in British Columbia, and on the lands of the Squamish, Tsleil-Waututh, and Musqueam nations. And to acknowledge that we are currently here today gathering on the lands, ancestral unceded territories of the Mi'kmaq people, and this territory is covered by the treaties of peace and friendship, which were signed in 1726. So what does individualization mean? So from this stock photo off of Google Images, you can see kind of what I see when I look at my patients, and it's really that those people living with HIV come in all shapes and sizes, from all walks of life, and from all nations. So they can look like anything, right? They can look like anyone. And so individualization means tailoring the medications, the treatment for the individual that you have in front of you, the person that you're treating. And there's good data, I'm not going to show it to you right now, but there's good data to show that a personalized approach working with a patient leads to increased patient engagement, right? Increased trust, and improved adherence to care, which then translates to undetectable viral loads, lack of transmission to others, and more optimal health for your patients. And so what kinds of things do I consider when I'm thinking about a regimen for a patient and thinking what I should give them? So I think about life stage. So for instance, if I have a youth in front of me who maybe struggles with adherence, as many of our youth do, has many years ahead of them and they don't want to acquire concurrent illnesses, for instance, or already has some resistance, I'm going to take that into consideration. If I have a woman who is pregnant or wanting to become pregnant, I'm going to consider that. So for instance, current guidelines would suggest that women who are expecting or planning to be expecting, you want to avoid 2-drug regimens or add a 3rd drug once they get pregnant, because we're not sure that 2 drugs are going to hold because of reduced drug levels in pregnancy. Similarly, the use of cobicistat as a booster means that those drugs, the levels will be lower in the 2nd and 3rd trimester. So you've got to really think about what drugs they're on, especially in 2nd and 3rd trimesters, as far as making sure we don't have viral breakthrough. Currently, most of the drugs that we're using, we have good data to suggest they're safe in pregnancy with lack of birth defects, but we have some of the newer agents that there's still data we're waiting on. So also being sure to talk about this with your patients. What about our midlife women? So women between their reproductive years and their post-reproductive years in their 40s and 50s gain on average, unfortunately, 10 to 15 pounds, okay? And so putting them on a regimen that may make them gain weight might be something that they don't want, right? And so that's something that you want to consider when you look at the person in front of you. And then looking at your more frail and elderly individuals. Does your patient have osteoporosis, for instance? If so, do you really want to be using something like tenofovir, right? Which we know will decrease bone density. And so I kind of look at all of these things around life stage. Okay, what clinical factors do I look at? I look at heart health and cholesterol, because I don't want to put them on a regimen that's going to make that worse if it's already high, right? I look at their weight. So for instance, one of the things we worry about for the cabotegravir and rilpivirine injection is a high BMI, right? So if it's very high, am I sure that I'm going to get that drug delivered where it needs to be safely for this patient to keep them suppressed, right? Or if they're already heavy, do I want to put them on a regimen that makes them more likely to gain additional weight? Kidney health. Certain drugs shouldn't or can't be given when GFR is really low. Okay, and then of course there's drug-drug interactions. So I have to see what other concurrent illnesses they're living with and what other drugs they're on, and make sure that I give them an antiretroviral regimen that plays well with their other drugs and doesn't cause them further difficulties. And then social structural factors. This is a really big one, okay? If you're on a regimen, so I used to use a lot of atazanavir once upon a time, okay? As an example, it needed a food requirement, as does rilpivirine, right? Both have food requirements for either tolerance or being able to absorb it, okay? If someone doesn't know where their next meal is, they have food insecurity, they don't have anything in the cupboard, they're not gonna take their ARVs, right? So you gotta think about their access to enough food. If it makes them nauseous, they're not gonna take it if they have nothing to eat. All right, substance use. If someone is using substances, are there substances that are going to interact with their medications, or are they going to struggle with adherence? And I should be considering a regimen that's going to be perhaps safer if their adherence isn't as good, or that is going to be easier for them to take in some way. Okay, other conflicting, priorities. Many of the people I care for have small children to care for, they have partners to care for, they have parents to care for, and many people care for everybody else before they care for themselves, right? And so these other competing priorities come into it as well, okay? And are they housed, right? If I want them to go to a certain place and get daily dispense, whatever it is, but they're actually camping all over town, is that going to work, right? So what I give them, how often I give them, depends on this too. And then things like stigma, so self-stigma and stigma that's really people don't want to go to this pharmacy near their home because the pharmacist recognizes them and is going to know they're HIV positive. So all of these things actually kind of come into what regimen they actually end up on in the end. And then that's not everything. Other things come into it, but many of the things, I guess the last thing that comes into it is what can I give them that's going to work, right? And so resistance profiles comes into it. So if they have a wild type virus, then my menu is long. If they have a virus like this, my menu is not so long. And what I can give them is markedly narrowed. So this is a Merck talk, right? So today I'm going to talk about where doravirine might fit into this picture just a little bit. All right, so I'm pretty sure that most of the people in the room are familiar with doravirine, but for those of you who might not be, this is the molecule. It's for the pharmacists in the room. I always like to put the molecule. I think it makes them happy. Maybe I'm wrong. That's the size of the pill. It's not as big as the one you see, but there is a little tape to show you how long it is, okay? It's an NNRTI. It's 100 milligrams once a day. It does contain lactose, so if someone feels sick and they're lactose intolerant, might be the case, okay? So just think about that. It's metabolized via the CYP3A4 pathway, and it's available either by itself or in combination with TDF and FTC as a single tablet regimen, okay? It has fewer interactions than other NNRTIs, so it's much cleaner, really, as far as interactions goes, and it has additional barrier to resistance than our first generation NNRTIs like nevirapine or efavirenz. All right, so here's a couple of cases. I'm going to blow through my slides really quickly, I think. Okay, a couple of cases. So here's the first case. Here I have a 35-year-old woman. She's living with HIV for the last 12 years, and her antiretrovirals were initially atazanavir, ritonavir, FTC, and TDF. Okay, and she was on that for quite a while until about 2 years ago when we changed her to a nice 1 tablet once a day of bictegravir, FTC, and TAF. Okay, since she got changed 2 years ago, she's gained 12 kilograms, or about 25 pounds. And she comes back to me, she's not very happy with me, right? Because she's gained quite a lot of weight. Her BMI is now 32, her cholesterol is 6.2, LDL is 4, and her hemoglobin A1C is edging up at 5.8. So she's looking metabolic, she's looking heavy, she's doing things to try and lose weight, but it's not working. So this is obviously not all the possible regimens, but I've got some ideas jotted down on what you can do. You could offer her a 2-drug regimen, or you could offer her a 3-drug regimen. Of the 2-drug regimens, some ideas: dolutegravir with 3-TC. Doravirine could actually go with raltegravir or dolutegravir. There's studies suggesting that either of those would be okay. Cabotegravir and rilpivirine. So those are your 2-drug regimens in someone with a wild-type virus. 3-drug regimens, you could pair 2 NRTIs, so either FTC-TAF or 3TC ABC, oh, I'm missing one actually, or FTC-TDF, right, as your backbone, with an NNRTI, an integrase inhibitor, or a protease inhibitor. Really, the menu is open. Okay, but let's start considering our individual. So when we consider her, we think that she might have been gaining weight because of her antiretrovirals, because she's not in that, transition to menopause period. She's still pretty young. She's 32, right? And since she's changed, she's had quite a marked weight gain without a lot of other changes in her life, okay? So what are the things that we know that cause weight gain? So there's been good evidence to suggest that integrase inhibitors are associated with weight gain, and tenofovir alafenamide, so TAF, is associated with weight gain. So if we kind of take some of those off, right, then our list is getting considerably shorter, right? We still have darunavir, atazanavir as options. Oh, I didn't take that one off yet. Sorry. Still have darunavir and atazanavir as options, but those are kind of alternate therapies, and they may make her cholesterol worse, right? The rilpivirine I've crossed out in orange there because rilpivirine has a calorie requirement, okay, of over 400 calories to be taken with the medication that's required for absorption. And I tell you, every person I've put on it orally has hated me because they invariably take it with their evening meal and then come back a month later, having gained weight, telling me they forget to take it with the evening meal, and then at supper have to eat another 400 calories, okay? And so it works great as an injectable, but it's less good in what I've seen as far as an oral for my patients, okay? So we're worried about weight gain, taking that one off, okay? And again, taking the darunavir and atazanavir off because of cholesterol and kind of a second, not my favorite. So that kind of leaves us, we've kind of cut off most of the things, and we're left with doravirine or etravirine, right, with FTC TDF or 3TC abacavir. And so that's probably the conversation I would have. Now, etravirine is 2 tablets. It's chalky. It tends to start dissolving in your mouth as you start to take it. So when people have to take the 2 side by side, they'd probably rather swallow the doravirine and then offer the backbone. So in this case, we ended up going with doravirine, FTC, and tenofovir because we could give it to her in a single drug regimen. She'd get 1 tablet, stay on the 1 tablet, but hopefully benefit from the favorable to neutral cholesterol and weight benefits of this regimen. And so I'm just going to give you a little bit of information from the studies that have shown that. Okay, so this is just a snapshot of the article from Lancet HIV by Orkin et al., which was published in the 2024, and it's from the Drive Forward and Drive Ahead trials for doravirine, okay? So this was safety and efficacy, and it's week 192 results, so that's about 4 years of follow-up from the open label extensions of those 2 trials. Okay, and so just a little bit about these 2 trials. People had to be at least 18 years of age. They had to have an HIV viral RNA of at least 1,000 copies. No prior antiretroviral treatment. They had to be naive, which was actually really hard to enroll. No known resistance to any drugs, and a GFR of over 50. okay? And individuals in Drive Forward were either started on doravirine with 2 NRTIs, which could be abacavir with 3-TC or FTC and tenofovir, okay, TDF. Or they were started on darunavir with ritonavir and, again, 2 of the backbone drugs. And then at 96 weeks, so approximately 2 years in, they were switched to open label where they went onto the doravirine arm, okay? The Drive Ahead trial, similar kind of a thing, except they were comparing doravirine with 3-TC and TDF, so that one-tab formulation essentially, with efavirenz, FTC, and TDF, which is, like Atripla would be the brand name, right? So comparing those, and then after 96 weeks, doing the open label switch, okay? So that's what those trials were. And the baseline characteristics of all the individuals in those 2 trials, okay, 747 individuals, 16% female, so we were talking about that beforehand, about that's never really enough for the women, especially because women make up half of people living with HIV the world over, so we do need to do better there. About 60% were white, and then other ethnicities, 29% Latin or Hispanic because of many of the studies being done in the US, and 21% ACB. Okay, mean age was pretty young at 34, and tenofovir, so traditional tenofovir, TDF, was the large majority of people in this study, so 93%. And when you looked at mean change in fasting lipids, okay, the first on the figure 1 on the left is when they were randomized to darunavir, okay, and then switched to doravirine, and the second is when they were randomized to efavirenz, then switched to doravirine. You can see their lipid levels, so from left to right, their LDL or bad cholesterol, their non-HDL, so non-good cholesterol, their total cholesterol, and their triglycerides. You see them go up on both efavirenz and darunavir, and then you see them go down when they start on doravirine. And so doravirine has had, in both those trials, a net beneficial effect on all of the bad cholesterol levels, okay? The one that's got little bars on both of them is HDL, or the good cholesterol, slightly positive in the darunavir to doravirine, okay, on both, with a slight loss of HDL when you went from efavirenz to doravirine, but not really very much, okay? And when they looked at weight gain on this study, so there's no good graph that I could find, but it was in the text of the study, the weight gain was approximately 0.5 to 2 kilograms over the study course for individuals involved in this study, which would be similar to population rates of weight gain. So as opposed to other studies, so studies of integrase inhibitors and studies including TAF, where weight gain was greater. Okay. And just a little bit more about lipids and weight gain. This study was presented at the European HIV Conference in Warsaw in 2023, the VICTOR study. Okay, so this was a real-life kind of a multi-center chart review, so a retrospective study of individuals who are 18 or more who were switched to doravirine-based antiretrovirals after they'd suppressed on another regimen. Okay, and this took place between 2019 and 2021, and they looked at the effectiveness of switching to doravirine. How did that work as far as viral loads? And it worked well, okay, but also what happened with body weight and lipids. And they assessed the data at baseline 6 and 12 months. And so the baseline characteristics of their 193 patients, this is really small writing, but I'm going to give you the things that I want you to see bigger and in red. So approximately 15% female. This is always how it is. I'm sorry, I'm sad. 15% female. Okay. Almost a quarter had a BMI over 30 in this study, in this switch study. Okay, that's important. A BMI over 30 would be considered obese. 80% had a concurrent condition, at least one other concurrent condition. And then what were people switching from? So approximately two-thirds were switching from an integrase inhibitor. About a quarter were switching from another NNRTI, such as efavirenz, rilpivirine, or nevirapine. 10.9% were switching from a protease inhibitor, and 58.5% had been on a TAF-containing regimen. And of the reasons for the switch, so this was real world, so this is people were asking to be switched, okay, in this study, 37.3% switched because of weight gain, okay? And in this study, the vast majority, so about 85%, changed to a regimen of doravirine 3-TC and TDF. And so what did they find? So this is the Coles Notes version here. The LDL changed from baseline, so this is your bad cholesterol, went down by a median of -7, and went down by 7.1 milligrams per deciliter, and in Canadian units that we use, it's about 0.2, okay? So LDL going down from like 3.5 to 3.3, for instance. For those who changed to doravirine FTC and TDF, so the single dose tablet, it went down a little further because the change from TAF to TDF would be expected to help your cholesterol. So it went down by 0.3. And then the weight change, for those who switched due to weight gain, okay, they lost on a median of 2 kilograms over the study time, so over the 2 years, so that's about 5 pounds, 2 kilograms that they lost. If they switched from TAF, they lost approximately 1 kilogram on average, and if they switched from an INSTI, they lost approximately 1 kilogram. All right, my next case. So this case is a 32-year-old young man who was always had HIV, so had perinatal HIV, had sequential ARVs as an infant. So if you do the math, that would put this person as being born in the early 90s. And that meant children born in the early 90s often got sick in the 90s when we still had not that many drugs, and so ended up getting sequential piling on of antiretrovirals, so starting with AZT, AZT3TC, AZT3TC, nevirapine. So they developed quite a bit of resistance and then became a teenager. And eventually came to me with this genotype. So integrase is sensitive, so that's not shown because that's still green, but you can see the rest of the resistance. And some adherence issues. So now this person is ready to get on medications and needs a salvage regimen. So what are the options? So the options is really a big discussion, right? So of our NNRTIs, if you look, it doesn't look very good, right? Because we're resistant to nevirapine, efavirenz, rilpivirine, and reduced to etravirin. But when we reran the sample, it showed up as sensitive to doravirine because it's got different mutations that impart resistance. Integrase inhibitors were preserved, and so we have dolutegravir, bictegravir, cabotegravir as options, okay? I guess elvitegravir or reltegravir as well, though those are first generation, and I'm feeling really punchy here with someone with so much resistance, so I'd probably want a higher barrier. Protease inhibitors, so we have a reduced response to protease inhibitors. I'm going to go back again. So you can see we're resistant to nalfinavir and then reduced to pretty much everything, including darunavir. So in this case, the only protease inhibitor I'd consider using would be darunavir twice daily, probably with ritonavir, because you'd get higher levels than you would if you used darunavir with cobicistat, but it becomes a negotiation about pills. There's GP120 inhibitors, so there's fostemsavir, which is twice daily, which is a new class that's now been approved. There's a CCR5 inhibitor, maraviroc, but this person was resistant, as you might expect. And then there's the new capsid inhibitor, lenacapavir. And so it becomes a discussion, what can we use, right? So, there's a couple ways you could do this, right? So today, you could maybe consider a long-acting injectable of cabotegravir or lenacapavir, right? But you could also, if you're going to go the pills route, maybe that's not available, maybe you don't want that. If you're going to go the pills route, something such as doravirine with your pick an integrase, dolutegravir perhaps, or bictegravir in the setting of bictegravir with FTC and TAF, okay? Your BID protease inhibitor, maybe fostemsavir. So I would be looking at a pretty layered and large regimen for someone like this who doesn't have much left, okay? And what about the use of doravirine in someone who's highly resistant, right? Should we be doing this if their geno shows us all this other red? right? So that's a question. And so a little bit of data about how safe is it to use that, right? Will this drug hold up? So this was actually also presented at the European HIV Conference in Warsaw by Chance and Brum from the BC Centre for Excellence in HIV and UB at St. Paul's Hospital. And he actually did a study where he looked at all the HIV protease RT sequences from physician-requested genotypic drug-resistant tests between 1996 and 2023. That was a lot. It was from over 10,000 people, and it was, I can't remember the number, but many, many samples, okay? And he screened for NNRTI resistance and doravirine resistance mutations. And what he found was that, about 20% of genotypes in the sample harbored NNRTI resistance of some kind, which isn't too much of a shock. 18-20% is something that I've heard too. Most of that would have been to efavirenz and nevirapine, and most of that in people who had experienced those drugs before, people who'd seen those drugs before. And you can see the middle bars of both graphs at the top. Okay, we have efavirenz on the left and nevirapine on the right show a 21 and 28% resistance to those in people who had seen those drugs before. Okay, etravirin resistance, because it's a little bit higher barrier, okay, a little more intermediate resistance, less outright resistance, and almost entirely in people who are treatment experienced for NNRTIs, okay? And then rilpivirine, a little bit more of a varied thing, because some of the rilpivirine resistance mutations cross-react with efavirenz and nevirapine. Okay. When you looked at doravirine resistance mutations, though, doravirine resistance mutations were only found in 5% of sequences from people who had seen NNRTIs previously, and much, much less frequently, so 0.5% in those who were naive, okay? And only 2.2% of sequences had more than one or more primary, 2 or more secondary, or 5 or more minor mutations, which would constitute doravirine resistance. Okay, so when you look at that, so that's pretty low, right? And when you look at the number of people who've had initiated doravirine in BC, okay, so this is from the same study, 230 people had initiated doravirine in BC. 75 of those 230 had history of NNRTI resistance mutations in the past. 40% of those were a K103N, which confers resistance primarily to efavirenz and nevirapine, okay? But 75 had prior resistance. And then the regimens they were put on, a small proportion were put on a 2-NRTI background with doravirine. 12 more were put on some combination of PI and doravirine, for instance. And then actually the vast majority were put on 4 or more drugs. So 68% put on 4 or more drugs. These are people who are quite resistant. Okay, and of all those people, of 75, or 230 people started on doravirine, 75 with prior resistance. There were only 3 cases of emergent resistance to doravirine over the study. Okay, and the vast majority of people maintain suppression. So it's valid. It's a valid tool, right? And it's a conversation that you can have with your patient about if you start a multi-drug regimen using this drug, okay, or whether you might start something else. All right, and my last case is a 67-year-old woman who's diagnosed in 2000, so she's been positive now for 25 years. She's been on efavirenz, FTC, and TDF since 2007, and has been really reticent to change, doesn't want to change, she likes it, right? She has asthma, for which she takes fluticasone, steroid puffer. She has osteoporosis, for which she takes calcium, magnesium, vitamin D, and alendronate. She has some sleep disturbance, and her and her family doctor are considering trazodone, okay, for sleep for her. She's a wild-type genotype, so no mutations. She's HLA-B5701 negative. Her BMI is normal at 23. Her cholesterol, total cholesterol and LDL are quite normal, and her kidney function is fine at 65, and she's hepatitis B immune. All right. So we're thinking of adding trazodone for sleep and to maybe help with some low mood and chronic pain symptoms that she's having. So here we are, our menu again. So this is it's not everything, but the usual suspects menu, right? And so what are we going to do with this? So first of all, if we're considering trazodone as a sleep aid and for mood and whatnot, atravirine and rilpivirine will interact with that, and you're a higher risk of arrhythmia, so you may want to avoid those. Darunavir, atazanavir, and elvitegravir are all boosted with either ritonavir or cobicistat, and they will interact with your fluticasone, so you can't take them out, but if you do that, you're going to have to change the fluticasone to beclomethasone so that you don't make her, give her too much steroid, okay? And also the boosted, PIs are no longer considered first line. Oh, I thought I had some more things. And then if her cardiac risk, so her cardiac risk doesn't actually turn out to be more than 10%, but another thing to consider, especially in our older populations, is if that cardiac risk is greater than 10%, you should avoid abacavir because of the potential increased risk of cardiac outcomes, okay? The data suggests, the basic science data suggests that abacavir makes your platelets a little bit more sticky, and so maybe a bit more likely to clot, and so if your risk is already high, it's something that you might want to avoid. And you might want to avoid an integrase inhibitor here because she's taking some divalent cations, so she's taking calcium and magnesium regularly through the day for her osteoporosis. That's not insurmountable. You can definitely do your timing, okay? And many people do, but it's just a consideration. So you might want to time them. So doravirine plus something such as FTC and TAF, which would be safer for her bones, or 3TC and abacavir might be something that you would pick, versus an integrase-related regimen, or perhaps one of the 2-drug regimens that's left there. Doravirine, raltegravir, and again, doravirine and dolutegravir also have been shown to be effective. And here is just one more slide from the Drive Ahead trial, which we talked about briefly before, showing that sleep disorders on doravirine as compared to efavirenz, which she's actually been on for many years, are half. And so perhaps that sleep disturbance can be cured by actually a change away from the efavirenz, which might be causing that. Okay, so that is all I have. And will I take questions, or we go to our next speaker?
I think we will go to the next speaker and then do questions after.
All right.
All right, how's everybody doing? First of all, listen, I want to congratulate all of you for being here between 5 and 6:30 as we stand between you, food, hockey, baseball, wine, the list goes on and on. So top marks for you for being here. So that was a wonderful talk by Melanie, and thanks, Sean, for that introduction. And Melanie really set the framework for this idea of the need to individualize therapy, and I really, through her 3 cases, I think we all appreciated that though we are making great progress in terms of new antiretrovirals, the need continues to grow to find that ideal option that's metabolically neutral, has good resistance profile, it's well tolerated. And so I get to present to you now in the next 30 minutes a little bit about a new agent currently under development. And some of you in the audience may be aware of it, some of you may not be, so we'll sort of walk through this. So it's titled A Novel Addition to the HIV Treatment Paradigm. The drug is called islatravir, and it belongs to an entirely new class called the NRTTI, and we'll get into that, which is a nucleoside reverse translocation transcription inhibitor. A bit of a mouthful, but we'll get into that. So my land acknowledgement, I work at McMaster University in Hamilton. I recognize and acknowledge that my home is located on the traditional territories of the Mississauga and Haudenosaunee nations and within the lands protected by the Dish in One Spoon Wampum Agreement. I've also added the local acknowledgement that you've heard earlier for being here in Halifax in Nova Scotia. My disclosures. So what we hope to cover in the next 30 minutes, and again, I make the assumption that some may be less familiar with this drug, is we'll talk a little bit about islatravir, the class itself, its mechanism of action, without putting you to sleep, I promise. And then we will talk about some phase 3 studies that were presented at the recent CROI meeting, and this may actually be the first time that many of you will be seeing this 48-week data. These are switch studies that were done, and we'll look at both efficacy and safety data around that. But for those of you that have been involved, and I have been involved as a full disclosure in the islatravir clinical trials, Those of you that were investigators in this trial may recall that the early phase 3 studies were actually initially stopped by the FDA because there was an unexpected signal that came up with islatravir with lymphocyte cytotoxicity. So the good news is we have addressed that, and we're still moving on with islatravir with a new dose, but we'll talk about the proposed mechanisms, because I think we're all interested in that was so unexpected, why did that happen, and we'll get into that. And then I'm going to end with, hopefully, again, after hearing those 3 amazing cases and the challenges that we face, and you've heard a lot already at this meeting about where this field is moving, and certainly we're looking at long-acting agents. So in fact, islatravir, not only is it available potentially, depending on how well it does through the development phase, as a daily treatment, it's also being explored potentially as a weekly treatment in combination with lenacapavir, a capsid inhibitor. So we'll talk a little bit about some efficacy and resistance data. So just to set the framework, and Melanie already did this, so I don't have to do any work, but just tell you that there still are unmet needs for antiretroviral options. We're looking for drugs that continue to have high potency, low toxicity, minimal drug-to-drug interactions, and metabolically neutral. And so with that in mind, islatravir, as I mentioned, is this NRTTI. It's currently being paired with doravirine, a drug that you've heard a lot about in the cases presented by Melanie, so I won't go into that, just to say that both of these drugs have a complementary mechanism of action and resistance profile. And so we may have, if this all goes well, another potential 2-drug option coming up. You've heard about the other 2-drug options through Melanie's cases. Now, just to set the framework, as I mentioned, the initial phase 3 studies that were started with islatravir doravirine in combination were with a dose of 100 milligrams of doravirine that you've heard about, and the islatravir dose that was used in the initial studies was 0.75 milligrams. Now, if you'll remember that dose, because that's the dose that was associated with the lymphocyte cytotoxicity signal and led to the initial halting of these studies and an exploration of why that's happened. But I'm going to move forward with the good news that we're still proceeding with islatravir doravirine development in a new phase 2b study, which was done, and it's been completed, and we're moving forward to, in fact, the phase 3 data that I will share with you, that looked at a new dose of islatravir, 0.25 milligrams, with the same dose of doravirine. And the reason this was looked at, and the slides to follow will explain that, is that there appears to be both a dose and time-dependent cytotoxicity signal that's been seen. So we've identified that it's very much dose-driven, but we'll get into that. And the good news is that with this new dose in the phase 2b study, which is really not powered for efficacy but did show effective HIV viral suppression, there was no effect on CD4 or lymphocyte counts. So a little bit about the mechanism. As I mentioned, it's called an NRTTI. The new word is the T, the translocation piece. So there are 2 sites of action. It's a translocation inhibitor. By doing so, it prevents the opening of the reverse transcriptase nucleoside binding site. And if you can't open that up, you can't incorporate nucleotides in, and that results in viral replication being inhibited. But it has a second mechanism of action. It changes the structure of the viral DNA. And again, by doing so, it prevents nucleotide incorporation from taking place. Again, the effect is that viral replication is inhibited. Now, islatravir is not in the reverse transcriptase active site, and that's a good thing, meaning it should be potentially less susceptible to resistance-conferring mutations. And anytime we see multiple mechanisms, it's generally speaking a sign of better potency, less resistance, but obviously those things need to be continued to be watched during the development phase. So just moving on a little bit about islatravir, the active form of islatravir is actually islatravir triphosphate, which accumulates in lymphocytes. And the islatravir triphosphate half-life in human PBMCs is around 200 hours. When islatravir, the initial phase 3 studies were done, they were actually looking at 3 different potential, frequencies of use: a daily dose, a potential weekly dose, and even potentially a monthly dose. And what this graph just shows you is that the y-axis is just a decline in lymphocyte count from baseline. And the green is that original dose, that 0.75 milligrams of islatravir that was used. And you can see that anything above 0.75 milligrams, that's the doses below. Those are the weekly doses of 20 milligrams and the monthly doses of 60 or 120 milligrams, all resulted in a decline in lymphocyte count. But what came out of the observation was it was very much related to the islatravir triphosphate concentration. That the magical cutoff appears to be, the safety net is that as long as you're below 9 micromoles, you have no cytotoxic signal. If you're above 35 micromoles, you are in that signal that will cause cytotoxicity. So in fact, on that graph, every one of those drugs, unfortunately, was above, in the original dosing that was used, was above the 35 micromoles, sorry. So the why, right? Fine, we noticed it, but we do want to understand why this happened. So both in vitro and in vivo studies were done. And I think that's something that we should congratulate the sponsor for doing, because we definitely wanted to understand why this was so unexpected when it happened. So on the in vitro side, what they did is they looked at the effects of islatravir and several NRTIs on TK6 cells. TK6 cell is a lymphoblast cell line, and they looked at population doubling and mitochondrial DNA contents were evaluated. They also looked at islatravir effect on human PBMC cytotoxicity, activation, and function. And lastly, they assessed the effect of islatravir triphosphate on its ability to inhibit human DNA alpha, beta, and gamma DNA polymerases. Because all of us that have been practicing for a while, the first thing I guarantee you we all thought when we saw this signal was, uh-oh, mitochondrial cytotoxicity. And so that's really why that was explored right away to answer that question. Now, on the in vivo side, they also looked at 3 different models, mouse, rat, and monkey, and pictures are often better than words. So you can see that they did not see any decline in lymphocytes in the rat model, up to doses as high as 50 milligrams per kilogram per day. They also did not observe any decline in lymphocytes in rhesus monkeys at doses tolerated as 20 milligrams per kilogram every 3rd day. But the one place where they did see a signal was, in fact, in mice. Where after 3 months of dosing at greater than 3.5 milligrams per kilogram per day, they did see a decline in lymphocytes. And what they did notice was the decline was seen in lymphocytes, in T and B cells, and even to a lesser extent in NK cells. And again, it was dose and time dependent. But one really important observation that trend in dose and time dependency was very similar to what was seen in humans. So now we could use this mice model to build on this and move forward to try to get some answers. So this is, again, looking at mice and looking at islatravir triphosphate levels at day 7. And it's just looking at the doses that were originally in the original trials. There was that monthly dose of 60 milligrams. There was the weekly dose of 20 milligrams. There was the daily dose of 0.75 milligrams. And as you can see, all of them, remember that magical number, 35 micromoles per liter is the cytotoxicity signal? All 3 of those exceed that 35 micromoles, the islatravir triphosphate concentration. But notice that the new dose that phase 2b study was done on 0.25 is well below that threshold and below that sort of 9 micromoles, which is really our safety signal to not see the cytotoxicity signal. Well, we know that all intracellular triphosphate levels for all NRTIs are generally driving the decrease in cell growth. So what's the mechanism? And again, I come back to this question of mitochondrial cytotoxicity because that was the first thing I guarantee you all of us thought. And so they did look at mitochondrial cytotoxicity. On the y-axis, you're seeing a mitochondrial to nuclear DNA ratio. And then you're seeing islatravir on the left, and then you're seeing 3 common NRTIs that we've been using, TAF, and 2 historical ones, DDI and DDC. So as you can see that with islatravir triphosphate, or even the phosphorylated form of TAF, there is no effect on mitochondrial cytotoxicity. But you remember with those historical drugs, thank God they're done, with DDI and DDC, we all saw a lot of mitochondrial cytotoxicity. So the answer is it's not driven by mitochondrial cytotoxicity. That's a good thing. That's not the mechanism why islatravir is caused with that initial higher dose a decline. But this needed to be done in order to prove that. All right, well, the next thing they looked at in vitro, remember, was to see what about the inhibition of alpha, beta, gamma polymerase effects to see. So again, what they did is they compared islatravir triphosphate to other phosphorylated forms of common NRTIs. So we've got tenofovir, we've got FTC, we've got abacavir, we've got 3TC. And what they found is that, yes, islatravir does inhibit DNA polymerase alpha, the IC50 of about 30 micromoles, but islatravir had no effect on DNA polymerase beta or mitochondrial DNA polymerase gamma, even as high as 200 micromoles, which is the highest concentration tested. But then the question comes up, well, if NRTIs inhibit polymerase alpha, and we saw that with islatravir triphosphate, then why do the other NRTIs not cause lymphocyte decreases? So to explore that, what they did is on the y-axis, you can see again, this is triphosphate concentrations in PBMCs. And on the x-axis are the therapeutic doses that we traditionally use for the existing NRTIs, right? So you've got DDI, ABC, abacavir, FTC, 3TC, and they again looked at triphosphate levels in PBMCs. And you can see that with the existing NRTI drugs that we have out, we don't get above, remember that magical number, 35 micromoles per liter? We're not close to that signal. But with the older formulations that were being explored for islatravir, that's 60 or 120 milligram, that's on the black bars, well above that threshold, right? The initial weekly dose that was being used was 20 milligrams. We are not using the 20 milligram dose going forward. We're using the 2 milligram dose. And you see with the 2 milligram dose, it is well below and very close to that safety threshold of 9 micromoles. And similarly for the daily dose. So I think this was, I mean, yes, this was a very unexpected finding, but I always say that, you know, having been around and doing clinical studies for a while, we have to recognize that a good amount of in vitro, in vivo work has been done to at least provide reassurance. It doesn't mean we don't need to continue to follow the signal, but I think a lot of reassurance. It's not mitochondrial cytotoxicity. It's certainly not just, you know, interference with DNA polymerase inhibition. It is dose dependent, and I think they've done a fairly good job addressing that concern. So that allowed the FDA and other regulatory bodies to allow these studies to go forward again. And the studies are now going forward with the new dose of 100 milligrams of doravirine, but that's 0.25 milligrams. And these are switch studies. So this is a study that was presented at CROI, and it's 48-week data. And just to walk you through this, these were patients that were virologically suppressed on Biktarvy for at least 3 months. They had to have no history of treatment failure on any regimen, and they could not obviously have resistance to doravirine. And those were the doravirine mutations at the bottom that they explored, which are the ones that are recognized as resistance-associated mutations for doravirine. Now, the last point is really important, and it's an interesting one. No active HBV infection. Now, how do they define active HBV infection? It was defined as the absence of being B surface antigen positive. But core antibody patients were allowed into the study. So we'll come back to that story. So the randomization was 2-to-1 to the doravirine arm relative to Biktarvy. The primary endpoint was standard at week 48, viral HIV RNA greater than 50 with a non-inferiority margin of 4%. This is a busy slide, but I'll just summarize it for you. The groups are matched at baseline, but I want to draw your attention to the bottom. The hepatitis B core antibody positivity. So if you notice, it's quite similar, but it's quite frequent. It's 25% in both the doravirine islatravir arm and the Biktarvy arm. So keep that number in mind, 25%. Let's go just to the treatment outcome. So the good news was it did meet its non-inferiority margin. So at the primary endpoint, again, was HIV RNA greater than 50 copies. The difference is 0.9, well within that 4% non-inferiority margin. But we're always interested, right? No matter what the non-inferiority margin is, we want to know more about the patients in that new treatment arm. So there were 5 patients, about a 1.5% failure rate for that primary endpoint. So what happened to those patients? Well, of those 5, 2 of them had confirmed HIV viral RNA greater than 200 copies per ml. But reassuringly, no treatment emergent resistance to doravirine or islatravir was detected in either patient. So at least from an efficacy perspective, that's somewhat reassuring. I did want to quickly touch, because it caught my attention, so I have to say it, the no data in window does look numerically higher for the doravirine islatravir arm, but this is a 2-to-1 randomization, right? But yes, some people may want to know more about that. But listen, we still want to look at we can't forget the safety signal, right? So the next thing they looked at, obviously right away, was effects on lymphocytes and CD4 counts. And here you go. The good news is there's absolutely no signal. So with the 0.25 milligram dose, there is no decline in total lymphocyte counts, and there's no decline in CD4 counts at 48 weeks. They did look at other safety signals. I'll just summarize it to tell you that the serious AEs were very similar in both groups, but Melanie did a great job through her cases talking about excuse the expression, the elephant in the room, weight. So we're always worried about weight, so let's just tell you about weight. So the mean weight change from baseline to week 48 in the doravirine islatravir was negative 0.03 compared to Biktarvy, which was 0.28. Yes, there numerically, that's a difference still of negative 0.30. The question that'll come up is that clinically significant? And we already heard from Melanie that there's an expected weight change that happens naturally, in Canadian populations. So I think that's for clinicians to address. And again, I'll leave that next bit, and we'll go to the interesting part, the hepatitis B, because everybody wants to know about that. So remember, 25% of patients were core antibody positive, right, in both groups. So let's just look at the doravirine islatravir patients. So they were broken down by core positive, surface antibody positive patients. That's around 21.6%. And then there was 3% that were core positive, but surface antibody negative. And in both of those arms, there was one HBV viremia event that was noticed. But the reassuring part is that both cases were low-level viremia, meaning if the viral DNA was less than 50 international units per ml, none of them had antigenemia, none of them had elevated transaminases. The one other interesting observation, I guess that's not a huge surprise, that there were 2 cases of acute Hep B. Now, that has nothing to do with doravirine and islatravir. I mean, Hep B is a common disease. Things happen. So there were 2 cases, incidentally, of acute HBV infection in the patients who were in fact, core antibody negative and surface antibody negative at baseline. I mean, that's an unavoidable entity that has nothing to do with the drug itself, per se, other than the fact that it doesn't have intrinsic Hep B activity. In the Biktarvy group, yes, there were absolutely no cases of virological breakthrough. The second study, also presented at CROI, is another switch study, but instead of switching now from Biktarvy, this is a switch study. It's an open-label design, and the switch is from a 2 or 3 drug regimen. So the design inclusion criteria is very similar. You had to be suppressed on your prior 2 or 3 drug regimen for at least 3 months. You had to have no history of treatment failure on any regimen. You obviously could not have resistance to doravirine. And again, you could not have active HBV infection with the same criteria, meaning not surface antigen positive, but you could be core antibody positive again and get into this study. Again, randomization was 2-to-1 to the doravirine islatravir arm. We're going to look at the 48-week data, which is the primary endpoint. The non-inferiority margin is again 4%. There was an open-label extension study, and I'm sure we will, in future meetings, hear about the extension part of it. But just again, looking at baseline characteristics, because this is now an open label with 2 or 3 ART therapy, what you really want to know is what was that baseline therapy. So 2/3 of the patient were INSTI-based. All right, 1/3 were NNRTI based, right? And that sort of makes sense because people were probably doing in-class switches. And so 2/3 INSTI, 1/3 NNRTI. Otherwise, fairly similar. Again, I draw your attention to the bottom line, the Hep B core antibody positivity, even higher in this one. So close to almost 30% matched, but 30% in both arms. Because I don't have a slide on Hep B reactivation, this one, I'm just going to tell you that there was 1 case of HBV reactivation in the doravirine islatravir arm in this study, none in the comparator arm. And again, in that 1 patient, it was low-level viremia, surface antigen negative, no elevation in liver enzymes, and it resolved. But we're looking at efficacy. So from an efficacy perspective, again, it met its primary endpoint, this 2-drug regimen of islatravir doravirine. Again, the non-inferiority margin is 4%, and as you can see here, a very low rate, 1.4% failure rate in the islatravir doravirine arm. Again, we're always interested in those 5 patients. So what about those 5 patients? Well, 2 of them discontinued early after virological failure at week 4 with multiple RAMs. These were present in baseline proviral DNA and, in fact, later found ineligible for the study due to prior VF or doravirine-related RAMs. So that's somewhat reassuring. The 3 discontinued post-week 48 with a viral RNA greater than 200. 1 had 215 T or I, which was not present in baseline proviral DNA. As you well know, this mutation has no impact on susceptibility to doravirine or islatravir. And 1 had V90I, also present in baseline proviral DNA, and 1 had a resistance assay failure. All right, so certainly that's the data on switch with looking at daily therapy, and we have now affirmed that the 0.25 from an efficacy perspective looks good. So far, the safety signal on lymphocytes and CD4s at 48 weeks looks good. But really, where this drug is also being explored is in a long-term long-acting algorithm, and what the study, which has actually been presented before, this is an ongoing phase 2b study, which is looking at the idea of combining weekly oral islatravir at a dose of 2 milligrams. I want to take you back to my original slides about that cytotoxicity signal. Remember, the original weekly dose was 20 milligrams that had the signal, but we're not going with 20 milligrams, we're going with 2 milligrams, right? Combined with oral lenacapavir, which is a new capsid inhibitor. So that's the phase 2b study. This is the actual design. Again, these were patients that, these are all switch studies. This is also a switch study. These are patients that have been on Biktarvy for more than 6 months. They had to have no history of virological failure. They had to have no evidence of HBV infection, and they had to have no evidence of NRTI or NNRTI resistance at baseline. This was a 1-to-1 randomization that was done to the long-acting arm of islatravir lenacapavir. If you're wondering about the doses, 300 of oral lenacapavir, 2 milligrams of islatravir, to standard single-tablet oral Biktarvy dosing. Primary endpoint is again going to be, exploration is at week 24. There's secondary endpoints at week 48, and then there's an open label extension arm that follows this. So the actual efficacy data, some of you may have seen. What I'm going to present to you is a little bit about some resistance data out of this in exploratory analysis. But for those that have not seen it, the good news is in this early 24-week look at the primary endpoint, we see that in fact the non-inferiority margin is certainly met. 94.2% in the islatravir-lenacapavir arm, 92.3% in the Biktarvy arm. So certainly from an efficacy perspective, seems to have met it. But the interesting part that was presented again at CROI was an exploratory analysis of pre-existing HIV resistance and on-treatment resistance data out to week 48 in the same phase 2b study. So what were the methods? So for baseline resistance testing, standard PR, reverse transcriptase integrase genotyping was done at screening using monogram, as well as historical HIV genotype reports were collected if they were available. So both were done at baseline. I'm not going to go through the individual mutations. Those are the standard RAMs that we link with these individual classes that were looked at. Now, just to mention, though, that absence, remember we mentioned in the initial inclusion criteria that absence of primary NRTI or NNRTI RAMs was, in fact, a screening criteria to get into the study. But if there were participants who initially at screening were negative for resistance, but subsequently found to have pre-existing resistance, they were allowed to continue in the study. And were included in the analysis, all right? What about the on-treatment, post-treatment analysis? So this was conducted for participants that had an HIV viral RNA greater than 200 copies per ml at the time of confirmed virological failure, and we define confirmed virological failure as viral RNA greater than 50 on 2 consecutive samples, or at studied drug discontinuation. And the methodology that was used was plasma HIV RNA genotyping and phenotyping using, again, GAGPro PhenoSense and gene sequence GAGPro and PhenoSense GAGPro. An alternate next-generation sequencing assay was also done in cases of assay failure. And what did we find? Well, we did find, in fact, that there was some pre-existing baseline resistance-associated mutations present in the 4 main antiretroviral classes. But the important point is that the numbers are very small. So let's just go through this. If you look at NRTI resistance, we're talking about 3.8% in either arm, islatravir, lenacapavir. Now let's go to those mutations. These are your classical TAMs that we're familiar with, but everybody's always interested in M184V or I. So there was one patient that had it, so 1.9% in the islatravir, lenacapavir arm, so we'll keep that in mind. NNRTI resistance, K103V1081. Remember, a third of the patients were, some of these are NNRTI experienced patients, so not a big surprise. PI, minor PI mutations, and then there was this INSTI mutation, T60A. Now, T60A is a non-polymorphic mutation that's usually selected out in patients that have had prior elvitegravir or reltegravir, but it actually has no effect on Biktarvy. So you did see that there was a 4.1% rate of this mutation seen. So what's the message from this? The message from this is that despite having, though this is low numbers, pre-existing mutations, it really did not seem to affect efficacy, right? And that's a reassuring part. Now, what about that whole on-treatment, post-treatment resistance analysis? Well, the summary to that is there was no patient that developed treatment-emergent HIV drug resistance. And so the messaging really here is that through this phase 2b study being done, long-acting with lenacapavir and islatravir, there's sufficient data to proceed to the phase 3 study, and in fact, we're participating, I'm sure many of you are, so that study will be rolling out very soon. And I think I'm going to end with that slide, but to say that again, having heard those wonderful cases from Melanie, this is just another example of another therapeutic option that we're going to have to figure out where we're going to position this. I think that's open for debate, who are the ideal patients for this. But just looking at some of those cases, I think there is potentially even, in some of the cases Melanie presented, this may have been a reasonable choice to have considered. So thank you, and I'll turn it back to Sean.
All right, well, we'll open it up for questions now. I guess I'll get the ball rolling. One question for you, Melanie. I know, we've been talking about weight was one of kind of the popular hot topic in HIV right now, and how often do you see weight changes in your population, in your patients, and how often are you ready to switch them to doravirine or something?
So we would check weight on patients kind of every time they come for a visit, and weight gain is a common thing. It's really discussion about what really is driving the weight gain. Is it slow weight gain that is coming with, perimenopause and menopause transition, or related to other social structural factors, right? Or is this thought to be something that might be related to the medications that they're on? And so there's usually a discussion around that, a discussion around how rapid it's been and whatnot. And then really it's often guided by the patient. What do they want, right? And so, we have a menu of options available, and, if they're unhappy with their weight gain and it's a possibility, then we can discuss other options that they can try, with the caveat they can go back if it's not for them, right? Yeah.
And Sharik, I guess, any thoughts on, I think there was some data presented at CROI this year about, if somebody misses a dose of their once weekly islatravir lenacapavir, is there any information about that?
Great question, Sean, and I think the quick answer would be not yet, but it's obviously an area of concern, and I suspect that many of us that are looking at this as a future option are probably thinking in our heads right away about who are going to be these patients, right? And I suspect we're going to be very selective in picking patients that have been highly compliant. This is just my own thought. We'll see what evolves. I actually think that there will be an appetite for this oral weekly option, but it'll be in that subset of patients that have quite experienced with respect to maintaining treatment, really adherent. I mean, if you give them the option of that once weekly option, and as I think, Sean, we were talking before the started, that there are obviously other drugs that are given weekly, often alendronate, is an example. So this is not something that can't happen. What happens if you miss a dose? That's, I think, a huge concern. But I think, so far this is being done within a controlled study environment. I think we're going to have to see in that phase 3 study that rolls out as to what the implications would be and what the response would need to be from us as primary investigators and physicians going forward. So I don't think we have an answer yet to it, but certainly it's an area of concern.
Hi, Lisa Barrett from Dalhousie. Thank you for that. Always love to see a new class, and to think more again about Melanie, what you were talking about with doravirine, because we didn't think about it for a long time, and now we are, and not just in folks who are older and have multiple medications. So your 34-year-old person who came. Interestingly, as we see more people coming into the country or having come from backgrounds where we don't know what they've had in different places or spaces, and they're on their therapy and they don't have suppressed virus, it becomes, I think, even more important to think about it. So that's a question. One of the people you see coming into the country, can be for either you, Melanie, and or Sharik, or anyone on the stage. I know some of you folks do more and more work with people new to Canada. Are you seeing people that have non-suppressed virus where you can't get previous genotypes? And is the doravirine TDF3TC something you're thinking about? If you only from virus based in serum. And the second question is for Sharik. When you're looking at those people that came into the study who were going to be on the once weekly, and you were looking at the resistance phenotypes, those were all suppressed people coming in. So I assume those were proviral.
Yes.
Proviral, okay, data. Do you know, or is there, and this will be the second question, do you know if there's any evidence of the little blips that we see of virus that are coming out with, for example, some of the entities? We know we don't think too much of it, but as we go further and further down the line, it might be something to think about. So the blippy bits, do you know if it happens? Yeah. And in people who are new to Canada, now have non-suppressed virus, and you don't know what they've been on before, is the doravirine 3TC and TDF something you think about?
Great questions as always, Lisa. So I can probably do the blippy one. Again, to the best of my understanding, that hasn't been seen. But remember, this is an early phase 2B study. So I always say that I suspect that some of those trends were probably going to be looked at more closely in the phase 3B when we have sufficient power in these studies to be looking at those things. But so far, I'm not aware. There may be some folks from the sponsor in here. I'm not aware of any such data. But is there anything someone wants to add there? That I don't believe so. Yeah. Okay.
Hi, Sharik. Thank you very much for the great presentation. I do have a question, actually 2 questions. So you did see a decline in lymphocyte counts, and you only did look at CD4. Do you have any data on CD8s count at all for these patients? That is question 1. Question 2 would be regards to the NRTTI drug. Sorry, I can't pronounce it.
That's okay, yeah.
But with that drug, have you, or is there any data with like people with like chronic kidney disease that are living with HIV? And are there any data on that?
Great question. So certainly there was a decline seen in all lymphocyte subsets, but to a larger extent on CD4, so less effect on CD8s. The other thing is that, I think this is an important thing to mention, is that they did look at all other cell lines, so there's no effect on RBCs, no effect on platelets. This is restricted to primarily CD4 subsets, lymphocytes, a little bit on NK cells, but not a huge effect on CD8. The chronic kidney piece, now for dosing, I don't want to say something at the top of my head about dosing, so I don't know the answer. Maybe one of these folks here about dosing on chronic kidney. I believe there's no adjustment that's needed, but this may be one where we can get the Merck folks in the back to pipe in. You can just shout it out, yes or no. Okay, good news is they're thinking as well, which means it's not an easy answer. Okay. I don't believe there's any dose adjustment piece that's there, but I can get back to you on that. It's a good question.
They may not have information on.
Yeah.
They may not have information on dialysis yet, or very low GFRs.
Yeah. Let's see.
Oh, here they come.
Yeah, here they come. There we go.
Hey, good afternoon. Benedict Funke, RDMA for Europe and Canada at MSD here called Merck. So regarding your questions, for the first one, viral blipping with doravirine and islatravir is going to be a subject of a presentation at a future conference. And regarding renal insufficiency, we have studied doravirine and islatravir up to a GFR of about 30, and there will be no dose adjustment required.
Yeah. Thank you.
And just to circle back to Lisa's question about what do you do if someone's coming in and you don't have any previous genotypes? So obviously if they're still detectable, then you would send a genotype and see, realizing that if they're not on medications, you may have no pressure and you might not see it till later. But kind of the history of whether they have gone up and down or if they've had a previous NNRTI. As we saw from the slide that I presented earlier, even if you've been exposed to NNRTIs before, and most people coming from abroad, especially from developing nations, are going to have been exposed to efavirenz or nevirapine and not to doravirine or etravirine in the past. And so even those who are highly treatment experienced, doravirine mutations were very few, and people generally suppressed even if they had those, right? If you're really worried, you can beg for proviral DNA assessment to see if there's any resistance. But that requires an email to Chanson from at the center. Yeah.
Yeah, I think that was the implicit question there, because I think we don't think about it enough, and some of the data that you presented makes me think a little harder. And I haven't been thinking hard enough, and often we get these viral loads that are not quite high enough to get anything substantive from, which is my least favorite situation. And my provirals, even in folks, especially if they're younger, if they were started somewhere else pretty quickly, that provirus isn't a ton there to get, and it's always quite frustrating. So I think you've made me think more about something I wasn't thinking about, and I'm not sure if you had any other things to add.
What I'm seeing a lot of is a lot of people coming in on TLD, so there's not as much of the efavirenz-based regimens anymore in the community coming into Montreal anyways. So there's less of that concern than there was in the past for the people that I'm seeing anyways. I think one of the important points that you brought up, Sharik, just as a kind of underlying theme, is just the importance of vaccinating for hepatitis B and making sure that we're covered. All our new regimens don't include any kind of Hep B protection, and so that's just something that I think we need to really reinforce too.
No, totally, I think that's an excellent point. And I think all of us are going to be interested as these studies evolve to continue to follow the signal, right? Because this question of occult hepatitis B infection reactivation is recognized, right? It's a recognized entity. It's fine that the 2 patients here and the 1 patient here didn't have any significant viremia, but I think certainly a preventive approach makes the most sense to make sure that they're vaccinated, but I think a surveillance, ongoing surveillance for this signal is necessary.
Great. Well, thank you, everyone. I think we'll end it for the evening and let you guys enjoy your night. So thank you very much.